is going to be about low back pain and intervertebral disc disease. I will cover all of the key points that I want you to be aware of for the upcoming exam. So low back pain is actually a very big issue in our country. It affects 80% of adults in the US at least once. And I can speak from experience in the emergency department. We saw many, many people daily with a complaint of back pain. Back pain is responsible for more lost working hours in persons under the age of 45 years old. So low back pain is common for a number of reasons. Our low back bears the majority of the weight of our body. It is the most flexible. It also contains a lot of nerve roots, and because of that, if there's any compression, we can have pain. And it just has an overall poor biomechanical structure. So we're going to do a case study, talk about DM. He is a 54-year-old gentleman. He's visiting his primary care and complaining of low back pain that has persisted for 3 weeks. So he states that the pain prevents him from doing certain activities like his regular golf game, and he's had minor pain before, but nothing that's been to this extent. He has been taking ibuprofen for pain when it's really bad. He's tried an ice pack with little relief. When obtaining a history on DM, what are some risk factors do you think that we would want to know from our patient as far as that can contribute to back pain? Well, I would think the big one would be, what do you do for a living? That's a huge one. Think about us. We're healthcare workers. Back pain is a substantial issue for healthcare workers. We definitely want to know, do they have excess body weight? Are they lacking in muscle tone? What is their posture like? Cigarette smoking. I know you guys at this point probably think I insert that on everything just because I'm so anti-smoking. However, smoking does increase calcium or decrease calcium absorption and prevent new bone growth. So it does play a part in bone conditions. We definitely want to know if our patients ever had any kind of fractures in the back, whether they have any congenital problems like maybe scoliosis, and family history. Another really big one is pregnancy. Women who are carrying this large amount of weight in the mid part of their body can experience back pain because of the compression on the nerve roots. So that's another thing to keep in mind. So when we talk occupational, of course, you guys are right up at the front lines. They're healthcare workers. Repetitive lifting, so your UPS, your Amazon Prime, mail people, they do a lot of repetitive lifting. Vibration. My husband's been a locomotive engineer for a quarter of a century. He sits on a vibrating engine for a long period of time, and it definitely leads to back problems. But you are a prime risk for that. So you've got to learn how to take care of yourself and your back so that you remain healthy to take care of other people. Usually it's due to musculoskeletal problems. So it could be a degenerative problem, osteoarthritis, herniation of a disc. Pain can be expressed in many different ways from our patient. They can point out a localized pain, or it can be very diffuse pain that even radiates into another part of the body. It can be radicular pain. So this is something like sciatica, where the pain will actually radiate down through the buttock and the leg, even into the foot. Or it could be referred pain. So that might be something like kidney pain that's referred to the back. So when we're talking about our gentleman in the case study, do you think his pain would be acute or chronic? So he's had this pain for 3 weeks. That would be classified as acute pain. So it's less than 4 weeks, some kind of stress or trauma caused the pain. And usually these things happen about 24 hours, or the presentation does, after the injury. This is why it's common for people who have maybe kind of a lighter car accident or a fender bender to decline treatment, and then the next day they're in the emergency department because they have all this pain when they wake up. So they could have aching pain, shooting pain. It's very common to see people come in bent over because they can't stand up straight. lot of different ways it can present itself. So our patient tells us he spent a weekend shoveling and spreading a truckload of mulch, and the pain started the next day. Well, that there is a pretty big indicator that he may have overdone it. What is some diagnostic testing that you might expect for the physician to order to look at what's going on with our patient and their pain situation? So you definitely may see an X-ray. You may see a CT or MRI if the patient has known trauma or we suspect some kind of systemic disease process, like perhaps bone mets to the bone with cancer. You can also do a straight leg raise test. So if someone has a disc herniation and we lift up their leg and it's straight and it radiates down into the lower extremity, that would be considered a positive. Other subjective things can be known disease like osteoarthritis or disc disease. We also want to know about their medications because if we find out the patient's been taking large amounts of ibuprofen or aspirin, acetaminophen, we definitely want to know why are they doing that. Have they ever had back surgery before? Have they ever had epidural injections to try and control pain? A lot of this will help us determine, acute versus chronic and what's been done in the past for the patient. We definitely want to know if they exercise. We want to weigh our patient. We want to look at their posture. Another thing is smoking, which we've addressed, but also constipation. So constipation can absolutely present as back pain. I've seen many a patient come in with severe back pain and it turns out they're impacted. So that is something to consider as well. That's considered obstructive constipation. Is it affecting their sleep? Are they able to work? These are questions we need to find out the answer to. Are they expressing numbness and tingling? Because we know that this is involving the nerves and more substantial situation. And are they, is it really impacting their life, their ADLs, their ability to work, etc.? So our patient undergoes an MRI and he's diagnosed with herniated discs at L3, L4, and L4, L5. So what additional clinical manifestations might we expect to see from this patient? Well, a big one's going to be guarded movement. They're going to be really conservative in how they're moving, may not be standing up straight. Do they have their normal reflexes? Can they do range of motion, or are they just really impacted by the pain? Now, what we can see on a CT or an MRI, as always, is any kind of structural problem. Just like when we have a patient come in who's having some neuro symptoms and we do a head CT, we're ruling out something structural, like perhaps a tumor. We can do the same things for the spine. We can see if they have nerve root impingement, where it's actually pressing down and then the pain is radiating from that impingement. When developing a plan of care, of course, we have to do our nursing diagnosis and ask ourselves, what things are we going to expect to be our nursing diagnosis? And of course, acute pain is going to be probably number one in your mind because the patient's there to see you because of pain. Do they have impaired mobility because the pain is so severe that they can't even perform their ADLs? Are they not coping well with the situation, using other means of coping, drugs or alcohol or whatever? And are they not managing their self-health and it's contributing to the problem? So there's many diagnoses we can have for our patient. Ultimately, our goal is that we want to relieve their pain, but we want to get to the bottom of the problem. We want to make sure they're exercising, doing physical therapy, that they get back their normal level of activity, and that they can stay on plan with the treatment. Now, when you hear the phrase proper body mechanics, this is something really important to you as a healthcare worker. You need to understand how to lift properly when you're caring for patients, because you're going to be assisting people in and out of beds and wheelchairs and many different things. So you really have to know how to squat and pick things up, how not to bend and pick up. Health promotion can include back school, where they actually go to physical therapy to learn these things. It's important to have proper body weight. It's important to sleep in proper positions. People with back pain should never ever sleep on their stomach. It's really not good for anyone. It's just not a normal alignment of the spine. Sleeping on their side with a pillow between their knees would be optimum for alignment. And then again, stop smoking, because we know that that causes problems within the bones. So our patient is advised to use conservative therapies for his pain management. And what do you think some of these measures might be? Because we're not going to jump right in and say, you need to have surgery, okay? So the first thing you can, I'm sure, think of is analgesics. So we're going to probably see the patient have possibly an 800 milligram ibuprofen, maybe a muscle relaxant could be given to them to help with the pain. Massage and back manipulation, which would be like chiropractic care, are definitely a possibility. Acupuncture has shown to work for some people. And then cold and hot compresses are good as well. So cold is going to reduce inflammation, reduce swelling, and heat is going to encourage healing. It's going to promote that blood flow with oxygen and nutrients. So you would alternate between them. Brief rest period may be necessary, but not lying in bed. The worst thing to do for back pain is lay for long periods of time. They need to be moving and doing some form of exercise. Definitely want to avoid things that aggravate the pain. So we don't want laying for long times. We don't want sitting in chairs for a long time. No lifting, bending, twisting. Need to really care for themselves. And the goal is to make this an isolated incident, to teach the patient how to avoid it in the future. If it's related to their job, definitely some occupational counseling to learn how to care for their spine so that they don't have this happen again. So this patient wants to know if he will ever be pain-free again, and what kind of teaching could we give him in that area? Well, the truth is, we hope that the patient can be pain-free, and we can give you the tools and the information to try to prevent the pain. So we're going to talk to them about how to sleep, how to lift up if they lay on their back and lift their knees or back, their knees or legs, so that they're in a proper position, never to lie on their stomach. We can teach them if they have to stand a long time in their job, that they can put a foot on a step stool. They need to maintain proper weight. They need to exercise daily. When carrying things, those things need to be close to the body, not out away. And they can alternate heat and cold. Also, they can use a lumbar roll at the back of the lumbar area, or a pillow for when they're sitting to add support. Things they shouldn't do is lean forward without bending the knees. That can actually be dangerous. Don't lift things above the elbows. That's too high and can add strain. Don't stand in one position for too long. We've talked about the sleeping. And they should always make sure they have their physician's approval before they do an exercise program, because they don't want to do exercise and injure themselves further. Now we're going to talk about chronic back pain. So we know that acute is something that happened. In this case of our patient, he was shoveling mulch and he did a lot of work and it led to injury. But now we're going to talk about chronic problems. So these are things that last longer than 3 months, or it's repeated and it's very incapacitating. Often it can be progressive, and it can come from a lot of things. It can be degenerative. They could have had a prior trauma or injury, chronic strain on the body, or even something congenital like scoliosis of the spine. So spinal stenosis, and you definitely want to understand these different categories, is a narrowing of the canal. So we know our spinal canal carries all these wonderful nerves, and as it narrows, we can have problems of compression and pain. So osteoarthritis is the most common cause. So you may hear about the patients with rheumatoid arthritis. Definitely someone who has a tumor could be having back pain, trauma, and even something called Paget's disease. Do need to be aware of what Paget's disease is. It interferes with the bone's normal recycling process. So bone tissue is gradually replaced, the old is replaced with new in our healthy body. But if that's not happening in Paget's disease, over time the bones become very fragile and misshapen, and that can lead to a lot of bone and joint pain. The lumbar area will be the biggest area complaint of pain because it's, again, bearing the weight of our body, and then any pressure on those nerves, it could radiate down into the buttock and the leg. It can be increased with any movement. It can lead to numbness, tingling, weakness. It can be very incapacitating for our patients. It's similar treatment to acute pain, but when this is a chronic problem, they're going to try different medications. So again, they'll try mild analgesics, and they may even introduce in some stronger pain meds, but only for small courses of time because of the potential for addiction. They may be given antidepressants because these drugs actually calm the central nervous system and can help with nerve pain. You may see a patient receiving gabapentin, which you may remember is given frequently for neuropathy in diabetic patients, and duloxetine, which is an antidepressant that can actually help with the back pain, again, because it's calming the central nervous system. So make sure you understand why they're giving these categories of drugs to someone with back pain. Weight reduction is huge. Resting but not lying for too long. Alternating heat and cold, again, cold to reduce inflammation, heat to promote healing. And most of these patients, they'll be in a physical therapy type program to strengthen their back, and something like back school. Now, as time progresses, if this is not working for the patient, we have to consider other options that would become more invasive. So the next step up that's minimally invasive would be like your epidural corticosteroid injections. So they can actually inject in the epidural space and provide pain relief for a period of time. If the pain is more severe, they can actually implant devices to deliver pain meds. So it's called a pain pump. And then there are surgical options that we'll talk about. So with intervertebral disc disease, the patient is having pain because the natural shock absorbers, which are the discs, are deteriorating and compressing and causing pain. So it can deteriorate and compress, it can actually herniate out, and it can involve any level of the spine. The most common, though, will be lumbar, again, because it's maintaining the majority of the weight of our body. Degenerative disc disease, when this is happening, the discs are thinning and basically drying out. And as it deteriorates, it can actually herniate out and compress on nerves and cause severe pain for the patient. So here's an example. It's a great visual to show you of what a normal disc looks like. It's a nice cushion. As it degenerates, you can see it's much thinner. And then it can have a disc here where it's bulging out. We have an actual herniation all the way out. Here's a very thin disc where you could end up with bone on bone and so forth. So you can see how our discs or natural shock absorbers are very necessary to prevent pain in our spine. Again, make sure you do understand what radiculopathy is. So you've got this pain, it's radiating. It can lead to numbness and tingling because of the nerve involvement, can limit the ability to have strength or even move in a range of motion and be very incapacitating for the patient. Osteoarthritis can lead to this. The most common sign, again, is low back pain because of the structure of our body. Keep in mind with radicular pain, we can do that straight leg raise test and it can be positive. So that we lift the leg and it's going to radiate down the buttock and leg. They can also have decreased or absent reflexes. When we talk about paresthesias, this is a progressing of the disease and weakness, and it's really impacting the patient. And these are going to be the candidates for surgical interventions. You do need to know what cauda equina is. This is a compression of multiple nerve roots. This can be a medical emergency because it can cause the patient to lose bowel and bladder incontinence in the lower lumbar area. If it's in the cervical disc area, the pain would actually radiate into hands and arms and cause trouble with reflexes and hand grip. But when we're talking about bowel and bladder incontinence, that's a medical emergency. That's not expected. So some of the different diagnostics. Well, we know about x-rays. Always they're going to start least invasive and truthfully least costly. Then they can move on to MRIs, CT scans, myelograms, and different venograms. But always they'll start with the least invasive test to see what's going on with the patient's spine. We, of course, like conservative therapy, which is resting, limiting movement, doing that alteration of heat and cold. Ultrasound is good. I'm sure you also know about a TENS unit. It's a possibility. Massage can be helpful, skin traction. And again, there's the TENS unit to give those electrical impulses to try and help with the pain. Now, when we talk about our drugs, again, we're going to always start conservative. So we're going to have our NSAIDs. We're going to try to reduce the inflammation to help with the pain. And short-term opioids, never long-term because they're so addictive. Our muscle relaxants, so like cyclobenzaprine. You may see anti-seizure drugs because, again, they're calming the central nervous system, so it may be helpful with the back pain. And the same with antidepressants because they calm the nervous system, central nervous system. And your epidural injections as the condition worsens. You do need to know what kind of back strengthening exercises are so important and why we do it. We need to strengthen the core of the body. So it's encouraged to do this for a lifetime. So the two key things that patients and we as healthcare providers need to know is how to do exercises to strengthen our back and to use good body mechanics. So know how to squat and pick things up and not bend and pick up. Because we want to take good care of our spine. It's important for chronic back patients to know that they need to avoid these extremes, and hopefully this can heal in a period of months. So when are we going to actually step in for surgical therapy? Well, that's going to be when all these other conservative treatments have failed. So we've tried the NSAIDs and the short-term opioids and the muscle relaxers and antidepressants and physical therapy and massage and heat and cold and exercise, and it's just not working. So if those things are failing and the radiculopathy is becoming so severe it's impacting their life, obviously if bowel or bladder control are lost, that would be a medical emergency, or if they just can't function because of constant pain or neuro deficits. So our patient, he develops this radiculopathy and has persistent pain, though he's been on these treatments for 4 months. So at this point, his surgeon or care PCP is going to contact a surgeon and try to figure out what are the best options for this patient. So we're going to just talk about a few procedures and I'll let you know what the key points are about it. Obviously, if we can do anything minimally invasive, that would be more important for our patient. So this procedure, the IDET, they're going to actually put a needle into the affected disc and they're going to put a wire in there and basically heat it, which is almost like an ablation, if you will. And the point is to stop the conduction through those nerves and therefore remove the pain signals. Another option is coblation nucleoplasty. So again, they're going to put the needle in and they're going to basically break up the inner part of that disc. And hopefully that breaking up that portion will lead to decompression and then relieve pain in that way. There is a procedure called the X-stop. This is actually a titanium mount that they're going to put into the vertebrae and lift it up off the pinched nerve. You might also, these are pretty common, see laminectomy and discectomy. So a laminectomy, they're going to remove the disc through excision of part of the vertebrae. And by doing this, hopefully relieve the pain. A discectomy, they're actually going to remove the disc and hope that that will decompress the nerve root and relieve the pain in that manner. They do have different artificial discs that they can put in to actually surgically replace the one that's leading to the pain and give more movement. So there is an image here. This is a Charite disc and can show you how they can basically put a new shock absorber in the spine. Spinal fusion. So this is where they actually fuse some vertebrae together. They can use a bone graft that comes from the patient's iliac crest or from their fibula. You can use cadaver bones. And they're doing this to add stability. They can add a metal device as well. And then they give them something called BMP to stimulate bone growth. And this is, obviously, these are very invasive and for patients who have been greatly impacted by their pain. So our patient undergoes a lumbar laminectomy with spinal fusion. What nursing interventions will you plan for with his post-op care? Well, the biggest one in the beginning is proper alignment. We have to keep our patient in neutral alignment. He's going to have limited activities. When laying down, we'll put pillows under the thighs if they're supine, and then on the side, we'll have the pillow between the legs. And just reassure our patient, because this is can be an alarming procedure. They will have opioid pain meds for the initial day or two with a pain pump, but as soon as possible, we switch them to oral drugs. We will give them muscle relaxants to help with any spasms that could go on and really monitor pain, and we should expect that it's improving on a daily basis. You do need to keep in mind when we're doing surgery on the spinal column, there is always a potential for a leakage of cerebrospinal fluid. So we have to watch our patients. One of the things they could complain of is a headache if that's happening. And we might see some clear or yellow drainage or discharge. So there is a test stick you can use that will actually test positive for glucose if it is indeed cerebrospinal fluid. That would be a medical emergency, and we would immediately notify the surgeon. We are doing frequent peripheral assessments and making sure that all of their pulses, color, temperature, and everything is as expected, and comparing it to their pre-op status. So someone, if they have problems pre-op, they may still have some of those problems, but it should, as the swelling goes down, it should improve. Now, if they have a complication that they didn't have pre-op, that's an emergency and you need to contact the surgeon. We're looking at their GI and bowel function. We want to definitely give them stool softeners because we don't want someone who just had spinal surgery to be straining. We want to assist them with their bladder emptying. And if there is any bowel or bladder incontinence, that is a medical emergency and we need to contact the surgeon immediately. We want them to have certain parameters for activity. They will know not to be bending and lifting over a certain amount. Some patients have to wear a rigid orthosis or a vest type device to keep them very aligned. And we're always, when dealing with the cervical spine, we're immobilizing their neck and watching for spinal cord edema because we don't want any permanent damage to come from that. If we have a donor site, just like any other surgical procedure, we have to assess that site for bleeding and any complications. It can be very painful and it would have a pressure dressing. So we're going to make sure that they still have good neurovascular function as expected. And teaching about activity, again, Proper body mechanics, I can't state that enough, especially for healthcare workers. And good exercise, walking, moving, don't sit, stand, or lie down too long, don't lift and twist. And use thighs and knees, squat down, and things of that nature. Also, not a soft mattress. They need to have a firm mattress or even put a bedboard in during this recovery time. So when caring for a patient following a lumbar laminectomy, the nurse should do which of the following. So you want to look at your different options here, and you should be selecting A, place a pillow between their legs before turning them to the side, because we want to keep them aligned, and that would keep them in a proper position. We don't want to twist the patient. We don't want them flexing or doing anything that's going to harm them. And that about wraps up back pain. Thank you.